Good evening and welcome to one and all of you for this CCI webinar for this week. I am Dr. P. Arjun from the Department of Respiratory Medicine, KIMS Health Trivandrum, and it's indeed a great honor and privilege for me to be the moderator for today's session. Now we know that CCI has been conducting webinars almost on all weeks for the past 1 year or so, and CCI, or the Chest Council of India, is one of the most vibrant organizations in pulmonology in the country today. Highly academically oriented group of pulmonologists led by Dr. Krishna and ably supported by Dr. Narayan Pradipha. They have actually revolutionized academic thought and academic ways in the country today. Let me take this opportunity to thank Dr. Krishna and Dr. Narayan Pradipha, and also Dr. Vijay Kumar Chamanchetti, who is the CCI webinar coordinator, for having invited me to moderate today's session. Now, the topic for the day is pulmonary renal syndromes. As we know, pulmonary renal syndrome is the presence of respiratory failure in a patient who has been diagnosed to have renal failure. It's a very challenging disease to diagnose. You need a high index of suspicion to make a diagnosis of pulmonary renal syndrome, or PRS, as it is often alluded to. There are a lot of causes for PRS. The most common one includes ANCA-associated vasculitis and anti-glomerular basement membrane disease. However, even rare causes like infections like the hantavirus pulmonary syndrome, legionellosis, and leptospirosis can lead on to pulmonary renal syndrome. There are many drugs that can cause this, as well as there are many other conditions, and including bronchogenic carcinoma has been reported to be a cause of pulmonary renal syndrome. Now, to speak about this topic today, we have a very eminent speaker, Dr. Sashi Kiran, who is working as consultant nephrologist in Yashoda Hospitals, Hyderabad. Dr. Sashi Kiran did his MBBS and MD from Kurnool Medical College and subsequently went on to do DM from Nizam's Institute, Hyderabad. He is an excellent academician, a great orator, has a very good track record in academics. He has a lot of publications, he has a lot of presentations. And what I found very impressive about Sashi Kiran was his contribution to Bill Gates and Melinda Foundation for prevention of Japanese encephalitis in our country. Without wasting much words, let me hand over the mic to Dr. Sashi Kiran to deliver his talk on pulmonary renal syndromes. Over to you, Dr. Sashi Kiran.
Good evening, everybody. Before I go any further, let me thank CCI for having me today for this talk. It's an honor and a pleasure for me to be with you this evening. Today we'll be discussing a little bit about pulmonary renal syndromes and what is of interest in this and what we can do about it. When we think about pulmonary renal syndrome, we're essentially discussing or dealing with a patient who has a diffuse alveolar hemorrhage in the presence of a rapidly progressive glomerulonephritis. This can be caused by a variety of mechanisms, the most important being an ANCA-mediated injury, which is the subject of intense research and interest. It can also be because of an antibody directed against the glomerular basement membrane and a similar collagen which is also shared in the alveolar of the lung. It can also be because of an immune complex deposition leading to a vasculitis of the small vessels, or it can be sometimes because of drugs. This can be classified basing on morphological criteria into the size of the blood vessels that are being affected, whether there is a granuloma or there is no granuloma, or basing on the immunological criteria by the presence or absence of ANCA, presence of immune complexes, or the presence or absence of an anti-basement membrane antibodies. It can be classified also basing on the etiology, whether it's an idiopathic or because of several secondary forms, which can cause the pulmonary renal syndrome. This brings us to a variety of differentials, but what we are interested in today and what we will be discussing is about the ANCA small vessel vasculitis, the anti-GBM vasculitis, anti-GBM disease to a little extent, because this is the reason This is the area of intense interest. The reason why I'm restricting myself to these two is because whenever we have somebody with an ANCA vasculitis, it has got a tremendous implication as far as the mortality risk is concerned when the kidney is involved. As shown here, if somebody has ANCA vasculitis with a renal involvement, his survival chances are much worse than compared with controls. And if we dissect this, as shown in this figure on this side, what we find is people who have a renal involvement with a PR3 antibody are the ones who fare much worse than those who don't have a renal involvement. Despite all the progress that has been made as far as the therapies are concerned, what we find is a significant proportion of patients with nephritis, especially when they have a renal failure with a GFR of less than 50, are the ones who progress to develop ESRD over a period of time, despite using the standard immunosuppressive regimens with or without a plasma exchange, and also with or without a high-dose glucocorticoid. And this makes us realize that it's important for us to detect these patients early and institute appropriate therapy so that they achieve a remission early, and this remission needs to be sustained for a longer period of time to have a better chance of survival. Those who achieve an early remission are the ones who have a better survival chances when we compare with those who have achieved remission a little bit late. The ones who fare worse are the ones who have a refractory disease or who have a relapsing disease, as shown in this table over here, where the three variables which are significant is the one where there is a late remission, or where there is a relapsing disease, or where there is a refractory disease. So when we talk about small vasculitis, we are interested about small vessel vasculitis, but also there's an occasion for us to realize that vasculitis can also affect medium and large blood vessels. The point of interest and point for discussion today is about small vessel vasculitis, because that's the one where the glomerulus is affected. The Chapel Hill consensus of 2012 was an update of the previous one. It remains descriptive as the previous one. The classification of the large vessel vasculitis and the medium vessel vasculitis remains the same as what it was in the previous one, but the only difference was with regards to small vessel vasculitis, where it was divided into two groups, whether there is a presence of ANCA or the presence of an immune complex. So the ANCA vasculitis is a syndrome of three groups which are overlapping: the GPA, the MPA, and the EGPA. The GPA is the one where the renal involvement is seen in up to 70% of the patients. The PR3 is much more pronounced than the MPO. The MPA is the one where the renal involvement is the highest of 90%. The MPO is slightly higher than the PR3 in this setting. The renal involvement is almost insignificant as far as the EGPA is concerned. When we look at the pathophysiology of the ANCA-mediated vasculitis, what we find is there is some inflammatory trigger which is triggering this whole process. And once the inflammatory trigger is there, what happens is an increased expression of the membrane, MPO, and PR3. And once there is an increased expression of these, then it's called a prime neutrophil to which the ANCAs get attached. And once the ANCAs get attached to these, what happens is a neutrophil activation, a degranulation, neutrophil extracellular traposis, and a cascade of these inflammation which keeps going on because of the further production of the MPO and PR3, ultimately resulting in an endothelial injury and the whole clinical manifestations of the pulmonary renal syndrome that we see. We have come a long way as far as ANCA is concerned. Initially, ANCA was thought to be because of an alveovirus infection, particularly the rotavirus infection way back in 1982. And we have learned a lot from that period of time. What we are interested in now is about the MPO ANCA and the PR3 ANCA as far as the PRS is concerned. The ANCAs can be tested in two methods. One is the indirect immunofluorescence assay, which uses an alcohol buffy coat. This is more sensitive, and it has two staining patterns. One is the C-ANCA, where you find a diffuse staining in the cytoplasm. Most of it is directed against the PR3. And there's another pattern which is around the nucleus, which is called the P-ANCA pattern, where it is directed against the MPO. Much more specific is the solid phase assay, the ELISA assay, where specific antigens, the MPO and PR3, are detected. We need to realize that when we are relying solely on the immunofluorescence assay because of the high sensitivity which it has, there are some pitfalls. The reason being the immunofluorescence results are by visual interpretation, and hence they're very subjective. They are unstandardized. And these patterns of P-ANCA can be sometimes non-specific and can be against other non-MPO or PR3 proteins. Another interesting feature is the P-ANCA pattern can sometimes be indistinguishable from the ANA, which is detected by IF. In other words, if we have a patient who has a P-ANCA positivity along with an ANA positivity, the ANA positivity most of the times is a false positive. Another interesting thing as far as this ANCA is concerned is when we look at the immunofluorescence assay alone, and this paper is based on several commercial preparations of immunofluorescence in the ELISA, not the ones which are in the research laboratories. This is based on commercial preparations. What they have found is when you look at the immunofluorescence assay alone, it is of no use. So it has to be correlated along with an ELISA, which is more specific. And to be much more precise, this needs to be done in a sequential manner. That brings us to a few questions which we keep asking ourselves when we are looking at the ANCA results. Is an ANCA positive test always a true positive test? Well, if you're using the immunofluorescence in the laser sequentially, that increases the positive predictive value significantly. So as and when it is possible, it's always mandatory for us to use IF and ELISA sequentially when we're testing for ANCA. So does a negative ANCA always exclude an ANCA-associated vasculitis? It may not be the case, because in up to 40 to 50% of the patients with mild to moderate disease, whether they have a GPA, NPA, or a EGPA, the ANCA can be negative despite them having the disease. And up to 10% of patients with either the GPA or NPA with a very severe disease can be ANCA negative. So an ANCA negative assay is not a certificate for not having a disease. Well, can we do away with the biopsy if an ANCA is positive? May not be the case in most of the cases, but can be possible only in one scenario where if the patient has a mild disease with a negative ANCA serology, the negative predictive value of a negative ANCA result can be up to 99%. So only in patients who have a mild disease where the ANCA is negative, you may do away with the biopsy, but in all other cases, the biopsy is something which is necessary, whatever may be the ANCA result. So a biopsy needs to be done whenever there's an opportunity to do it. So when we are monitoring an ANCA, there's an increase in the titer predict a flare. So whenever you're monitoring a patient with vasculitis, you need to follow the patient very closely and alter the therapy according to the clinical indications. And elevations in the titer of ANCA may not be a good idea to monitor your therapy. It should be always basing on the clinical condition of the patients once they're diagnosed to have an ANCA-positive vasculitis. That brings us to another question where if an ANCA is persistently negative, does it indicate that the disease is quiescent? Well, this may be a case in a patient who was positive earlier with an active disease and now is negative with no clinical manifestations. In such a scenario, a negative ANCA result can be reassuring for him. So how do we classify and diagnose these patients, the criteria has been evolving over the last 30 years. The first was the ACR criteria in 1990, the American College criteria of 1990. This criteria was formed to standardize the research at that point in time, and it did meet the goals to a very large extent. The major drawback of this criteria came up in a time and generation where the MPA was not recognized to be a separate entity. So solely basing on this criteria, there's no way we can distinguish between a GPA and an MPA or something which is mimicking a GPA. The next was the Chapel Hill consensus criteria. This is not actually a criteria, but a set of definitions, as told earlier, to make us identify the small vessel vasculitis was because of an ANCA or because of an immune complex mediated. And in those with an ANCA, whether they have a granuloma or they don't have a granuloma. Though the potential value of ANCA serology was identified and mentioned in the Chapel Hill consensus criteria, it's not included as a criterion for the diagnosis. Another one is the European Medicines Agency algorithm. What it does is it combines in a stepwise manner or sequentially the criteria of the ACR and the Chapel Hill criteria to see that we first diagnose patients who have eGPA and then go on to exclude patients who have GPA and only then come to diagnose a patient as having an MPA. So when you have to diagnose a patient as having an MPA, you need to rule out the eGPA and the GPA according to this algorithm, which is unuseful. What is new as far as the causation of small vessel vasculitis is this paper on the genetics of small vessel vasculitis. This is based on two large genome surveys of North America and Europe. What they have found is a genetic association with the PRO or MP3 ANCA and not with clinical diagnosis of GPA or MPA. So the genetic association is with the PR3 or MPO. So the PR3 being consistently associated with HLA-DP and PRTN3, that is proteinase 3, and the MPO being consistently associated with the HLA-DQ, which is entirely different from the other HLAs of the PR3 ANCA. And both of these can be associated with SERPINA1, which codes for alpha-1 antitrypsin, and also for PTPN22, which is linked with the T-cell activation. So slowly, we are moving from an era where we were categorizing a disease as a GPA or an MPA to an era where we will be categorizing a disease either because of a PR3 ANCA or an MPO ANCA. It's not there, but I think eventually it will be going there. A clinical presentation, I'm sticking only to the renal manifestation. What we find is up to a fifth of patients can have renal manifestation, some form of renal manifestation at presentation, but more than 80% of them will have renal manifestations by the end of 2 years. So manifestations can be as simple as hematuria, going on to a milder form of renal failure along with proteinuria, and then to a rapidly progressive glomerulonephritis, eventually progressing to end-stage renal disease. So the renal manifestations are pleomorphic, and it comprises the entire spectrum as far as these vasculitis leading to PRS is concerned. When we look at the histopathology, what we are finding is a rapidly progressive glomerulonephritis or the presentive glomerulonephritis. And the histopathology is something which can also help us to predict what is going to happen for these patients in future. The way it is now favored to be classified is to look for a sclerosed glomeruli. If more than 50% of the sample to glomeruli are sclerosed, then it goes to a sclerotic class. And if that is not there, we look for the sclerosis. If it is less than 50%, we look for if the glomeruli more than 50% are normal, and if that is the case, then it goes to a focal class. And if more than 50% of glomeruli have cellular crescent, it becomes a crescentic glomerulonephritis. And if this is not the case, then it's a mixed class. So what we are finding is, as the sclerosis increases, the prognosis becomes more and more worse. Patients who have a sclerotic glomeruli are the ones who are progressing to end-stage renal disease, and the ones with mixed ones are having a mixed results. The ones who have only a focal involvement are the ones who do well. And this has made several people come up with a scoring system so as to predict ESRD right at the baseline of diagnosis. ESRD is the end-stage renal disease. So we have a burden classification. This is exactly the one which I discussed in the previous slide. We also have a Mayo classification and also another class, and also several other classifications. But essentially, all these classifications are looking at only the scarring. And what is evident is it is the scarring which is driving the patient towards ESRD, despite institution of the therapy. In other words, the current therapies are probably insufficient to control the smoldering activity. So despite our best efforts to institute everything at our disposal, once the scarring is present, the progression to the ESRD is something which is not preventable. So how do we manage these patients? The first one, what we need to do is, once we make the diagnosis of a GPA or an MPA, is to see if they have an anti-GBM disease along with that. If they have an anti-GBM disease along with that, then we need to institute, apart from standard induction regimens, a plasmapheresis. If there is no concomitant anti-GBM disease, the next thing what we are going to look for is to see if they have any organ-threatening or a life-threatening feature, which can be in the form of an acute glomerulonephritis or a pulmonary hemorrhage or an eye disease leading to a visual loss or a threatening visual loss, a GI bleed, or a cardiac disease. If any of these or all of these is present, then we need to go ahead with an induction therapy, which can have either rituximab or cyclophosphamide or both, along with steroids. If there is no organ-threatening or a life-threatening disease, then we can probably go for a milder regimen, which constitutes glucocorticoids along with methotrexate or rituximab. In those who have a severe form of disease and we institute rituximab or cyclophosphamide, if they attain a remission within the 6 months, then they go for a maintenance therapy. If they are not attaining remission within 6 months, then they are categorized as having a resistant GPA or an MPA. So when we look at the induction therapy, broadly it is either a rituximab-based regimen or a cyclophosphamide-based regimen. Rituximab can be given in two possible ways: 2 doses of 1 gram, 14 days apart, or 375 milligrams per meter square per week, every week for 4 weeks, along with glucocorticoids. The cyclophosphamide-based regimen, most of this is basing on the Cyclops study, which came almost a decade and a half ago. It can be an IV regimen where 15 milligram per kg every 2 weeks for 3 doses, and then every 3 weeks for 3 to 6 months in combination with glucocorticoids, or an oral regimen of 1.5 to 2 milligram per kg for 3 to 6 months. In both these regimens, either an IV or an oral, the rate of remission induction was almost equivalent, whereas the cumulative dose of the drug was less in the IV regimen, and thereby a slightly lesser degree of adverse events in this regimen. So there are two important trials which have looked into the rituximab-based regimen, cyclophosphamide-based regimen, one of which is the RAVE trial, which was a randomized placebo-controlled multicenter trial, which was essentially to look for non-inferiority of rituximab over cyclophosphamide. So rituximab was given once a week for 4 weeks, dose of 375 milligrams per meter square, along with cyclophosphamide in another arm, oral cyclophosphamide 2 milligrams per kg per day, along with methylprednisolone. So what was seen here is rituximab fared consistently better both at 6 months, 12 months, and 18 months as far as inducing a remission is concerned, and also in those patients who have a relapse in disease at presentation. What's important for us to note in this paper are two things. Rituximab faring better in relapsing disease. So probably rituximab is something which has a role in a relapsing disease. But it comes with the caveat that this paper didn't contain patients who have an alveolar hemorrhage requiring mechanical ventilation, and those patients who have a serum creatinine more than 4, which makes us feel probably the heart of patients in this study were not as severe, and probably in patients who are more severe than this, cyclophosphamide would be better alternative, or maybe a cyclophosphamide along with a combination of rituximab. So this was something which was looked into in the rituximab study, where they have used rituximab along with cyclophosphamide and compared it with cyclophosphamide alone. So what they found is combination of rituximab with cyclophosphamide gave a better result than cyclophosphamide alone. So in other words, if we're dealing with a patient who has a very severe disease, it would be wise for us to use methylprednisolone, rituximab, and cyclophosphamide, all three as part of the induction regimen. And plasma exchange has been a contentious issue, whether to be used in the induction regimen or not. There were several studies which were part of this meta-analysis and mentioned in this forest plot, which favored the role of plasma exchange. And this also includes the MAPEX trial of 2007, where these studies favored the role of plasma exchange as far as small vessel vasculitis patients having a severe disease is concerned. But of late, the consensus has been more divided. And this paper, which is a retrospective cohort study where they have found whether you use plasmapheresis or no plasmapheresis, whether you use a high dose or a low dose steroid, what you're finding is there is no difference as far as the outcome is concerned. So this made people to look for a prospective study to address these issues, and the PEXVAS is something which has addressed this issue. What the PEXVAS has told or showed is whether you use a plasma exchange or no plasma exchange, the result is the same. In other words, plasma exchange has not yielded any significant advantage over the standard induction regimens of methylprednisolone, cyclophosphamide, along with rituximab, as far as the patient's outcomes are concerned. But there is a general consensus among the treating physicians, and also recognized by the criteria of the Dermatology Association of 2016, where there are a few categories where you need to use plasmapheresis. The undisputed category is the double positivity of the GPA or MPA with anti-GBM antibodies. And those patients who are dialysis dependent or presenting with a creatinine of more than 5.7, which is about 500 millimoles per deciliter, and those with pulmonary hemorrhage. Probably there's a general consensus to institute plasmapheresis in these three subsets of patients. And whenever the plasmapheresis is being instituted, The ideal would be to give at least 7 sessions, and each session being about 60 ml per kg exchange with human albumin. And whenever there is a risk for bleeding, you will be substituting the last 1 to 1.5 liter with fresh frozen plasma. But over a period of time, I'm sure the role of plasma exchange as far as this disease will evolve, and we will be having a clearer idea of whom to be taken up for plasmapheresis and whom not to. So when a patient has achieved remission by 6 months because of the induction regimen that we have instituted, that is the time to start the maintenance therapy. So any patient who has received rituximab for induction starts the maintenance therapy about 4 to 6 months after the last dose of rituximab. And if he has received cyclophosphamide, he will be starting the maintenance therapy about 2 to 4 weeks after the last dose of cyclophosphamide. The agents that are used as far as the maintenance therapy is concerned is prednisolone along with either rituximab, which is 500,000 milligrams every 6 months. Sometimes it can be used in an on-demand strategy, or it can be an azathioprine 2 milligram per kg per day, the max being about 200 milligrams per day. Or in certain scenarios where there is not much of a severe disease and in the absence of renal failure, you can use methotrexate 15 to 25 milligrams per week, or mycophenolate mofetil from 1.5 to 3 grams per day. So there are a few studies which try to see how each drug fares against the other. One of that is the MAINRIT-SAN study, which tried to compare rituximab with azathioprine to be used as maintenance in patients who have got cyclophosphamide. What was found is rituximab fares much better than azathioprine as far as a drug for the maintenance therapy, to see that the patient has a disease-free period and very minimal relapses. Another 2 studies which compared cyclophosphamide with azathioprine is the PSYCH-as-a-RAM study, where it was shown that azathioprine was not inferior to cyclophosphamide as a maintenance drug. And in fact, azathioprine group had a fewer side effects or adverse events when compared with cyclophosphamide group, favoring the use of azathioprine as a maintenance therapy. Another one is the IMPROVE study, which tried to compare azathioprine with mycophenolate mofetil. What they found is azathioprine faring much better than mycophenolate mofetil in trying to see the patient remaining disease-free. This makes us conclude that azathioprine probably is a drug which fares better than mycophenolate mofetil or cyclophosphamide, but it's rituximab, which is the one which has the best result as far as the maintenance therapy is concerned. This brings us to the question how long we need to institute the maintenance therapy. As shown in this paper, patients who were stopped maintenance therapy after 2 years were the ones who fared much worse than those where the maintenance therapy was continued for 4 years. In other words, the longer, the better as far as the maintenance therapy is concerned. Since the time the role of complement was recognized as far as the small vessel vasculitis is concerned, this became another target for us to act upon to see that the disease is under control. So the new drug that has come up to target the complement is the C5a receptor antibody, this is the avacopan. Avacopan was used in combination with prednisolone or alone and compared with prednisolone along with placebo. And what was found is avacopan alone had a better result in controlling the severity score and also in reducing the urinary albumin creatinine ratio and also in decreasing the urinary MCP creatinine ratio than when it's combined with prednisolone or when prednisolone is used alone. And also, in this study, it was shown that avacopan is something which fares better than prednisolone as far as preventing a relapse is concerned. So avacopan, 30 milligram twice a day, an oral molecule as a maintenance therapy probably will be the drug in future for us to use. Another important thing as far as the pulmonary renal syndrome is the anti-GBM disease, and also conditions where we have a double positivity of ANCA and anti-GBM disease. So anti-GBM disease is where you have an IgG1 or G3 antibodies against the NC1 domain of the alpha-3 chain of the type 4 collagen. This is the one which is shared both in the glomerular basement membrane and the alveoli. So patients who have an anti-GBM disease come with the pulmonary renal syndrome, and there's direct correlation between the levels of the anti-GBM antibody and the disease manifestation. So whenever we have a patient who have an anti-GBM disease or who is double positive for ANCA and anti-GBM, what we need to institute is a plasma exchange along with corticosteroid and cyclophosphamide, especially if the patients have got a pulmonary hemorrhage, they are needing dialysis. There are young patients who can tolerate such intense therapies, and also those patients who have focal cruisants with acute tubular injury. We need to be more aggressive with these patients and try to use all three modalities of therapy to see and control the disease. So when we're using plasma exchange for them, we use plasma exchange for up to 2 to 3 weeks, the initial 2 to 3 sessions being on once a day basis, and the later sessions being every alternate day, and albumin being used as a replacement solution. And typically the plasma exchanges are up to 4 liters for every session. And corticosteroids need to be used for about 6 months, and cyclophosphamide to be used for about another 6 months. In patients with anti-GBM disease who don't have a pulmonary hemorrhage and who present with a creatinine of more than 6 and are dialysis dependent at presentation, probably these therapies may not be necessary, because none of these therapies are going to help them prevent from progressing to end-stage renal disease. In other words, it's a very bad scenario for somebody to present without a lung hemorrhage with a creatinine of more than 6.5 and being dialysis dependent at presentation. So these are the ones, despite all the efforts, they progress to end-stage renal disease. So what are the trends in the long-term outcome with the evolution of the therapy and diagnostics over the last 30 years is something which was looked into in this paper. What was found is there was a significant improvement as far as the outcomes are concerned when we're looking at a cohort between 1985 and 1989 to the cohort between 2005 and 2009. What is more important and interesting for us to note is there is not much difference as far as the improvement is concerned in the recent years. So over the last 2 cohorts, the outcome has been more or less the same. So there has been some improvement, but it has come to a standstill, which should make us look more deeply into this group and what we need to do as far as the improvement in diagnosing the disease early and therapy is concerned. So I'll try to conclude that ANCA-associated vasculitis is a contentious issue as far as the pulmonary renal syndrome is concerned. I've tried to restrict myself only to this because this is the one where a lot of work and interest is located. And for a better outcome, early recognition is the key. And when we're testing for ANCA, we need to use both immunofluorescence and ELISA, and that is sequentially. And for induction regimens, rituximab needs to be combined with cyclophosphamide to have a better remission rate. The role of plasma exchange is evolving. We'll be knowing more about this in future. And the duration of maintenance regimens, it appears the longer the duration, the better is the outcome. So there is a small trade-off as far as attaining the remission is concerned and accepting the adverse events are concerned. And the role of new molecules like the avacopan and a few others in the pipeline is something interesting for us to have a watch. Thank you once again.
Thank you, Dr. Sashi Kiran. That was a wonderful exposition of ANCA-associated vasculitis and pulmonary renal syndromes. You also alluded to anti-glomerular basement membrane disease and its importance, and why the alveolus and the glomerulus are the common targets of that antibody. Now, let's open this session for discussion. There are a lot of questions from the audience. We will take it one by one, and so that you can answer them. So the first question is from Dr. Srikanth from Chandigarh, who was asked that in a patient who has ANCA-associated vasculitis in remission, if he comes with new onset respiratory failure and worsening creat levels, how do you differentiate disease activity from other causes, and how do you proceed in such patients?
Let me restrict myself as far as the renal manifestations are concerned. Essentially, what we are looking here is he having a relapse or is he having something new? So many of these diseases are proliferative in nature as far as the glomerulonephritis is concerned. So a proliferative glomerulonephritis picture is something where the patient has the RBCs and RBC casts in urine along with an increase in proteinuria, along with the worsening of renal function. So if the patient is coming back to me with RBC casts in urine, a worsening of the proteinuria, which was better before, and the worsening of renal function, probably I'm dealing with the person who has come back to me with a relapse. So these are essentially the renal part of the disease that I'm going to look for. And if I'm satisfied with this in the absence of other infective etiology, probably we are looking at a relapse and we are going to treat them as a relapse.
Thank you. The next question is from Dr. Arjun Raja from Chittoor, who is asking if ANCA is negative by immunofluorescence, should we order it by ELISA, or should we order PR3 and MPO qualitative quantitative levels if the suspicion is high?
As mentioned, there are some pitfalls as far as the ANCA by immunofluorescence is concerned, because it's a test which is subjective and there's no validation or standardization. So I would say, like, what I would do is to go for both the immunofluorescence and also the solid phase assay, the ELISA. So if you go sequentially with the immunofluorescence and also the ELISA solid phase assay, that is the one which will pick up the patients who have real ANCA positivity rather than going for a quantitative one.
Thank you. Dr. Arjun Raja has asked another question also. What are the causes of rituximab failure, and how do you investigate such cases?
Rituximab failure. See, any induction regimen, whether it's rituximab or whether it's a cyclophosphamide or whether it's used in combination, it can fail in some of the instances. When we don't find a remission within 6 months, that is where we are characterizing these patients as having a resistant disease. And when we are facing a resistant disease, what we are going to do is to switch from one regimen to the other regimen. Suppose if he is on steroid with cyclophosphamide, we try to put him on a rituximab-based regimen, or if he is on a rituximab-based regimen, we try to switch him to a cyclophosphamide-based regimen. But if he is on both, we try to add a mycophenolate mofetil into this. So failures, there is a definite subset of patients who fail, and that's an area where a lot of research is going on. And these are the patients who fail for a variety of reasons, where they're unable to tolerate, disease is very severe, they're coming up very late to us. Most of the times, what we find is a patient who has a renal disease is the one who is coming late, who is presenting late. If they have an upper respiratory tract symptoms, they are the ones who come early, who respond better, and who are the ones who get into remission very early. Those who don't have many of the upper respiratory tract symptoms, or who have only a renal manifestations, they are the ones who are coming late. They are the ones who are not getting into remission that easily. So that is how I would look at it.
Thank you. Dr. Sagar Gandhi from Nagpur has asked the question. Could you kindly go through the pathogenesis once more and elaborate what makes the disease refractory? I think you've already shown that.
So, as far as the pathogenesis is concerned, what is something is there's a trigger which comes up. Once there is a trigger, the MPO and PR3, which are normally in the cytosol, they come up onto the surface. And once the cryptic epitopes of these antigens come up or get exposed, to which the ANCAs go and attach. So there is also something called an epitope sharing which happens. So the process becomes even more widespread. More and more antibodies getting attached to these neutrophils, the neutrophils getting activated, and they go through a process of degranulation, which is actually a cascade, and it gets magnified significantly, leading to the disruption of the endothelium. That is how it happens.
Thank you. Dr. Arjun from Chittor again. He wants to know the causes of false positive ANCA.
False positive ANCAs, like there are a variety of rheumatological diseases which can cause false positive ANCAs. Also, infective conditions, if I can mention the like infective endocarditis, sometimes monoclonal gammopathies. So there are a host of other conditions which can cause an ANCA false positive, which can be rheumatological, infective, plasmacytomas. So you need to take the clinical scenario into the context and not just rely on ANCA as far as diagnosing is concerned.
Yes, asked one more question.
Yeah.
How do you manage refractory disease which does not respond to both cyclophosphamide and rituximab?
I just told a short while ago. So what we are trying to do as far as the refractory disease is to expose him to another set of drugs to which he was not exposed before. So if he was exposed to rituximab, I try to give cyclophosphamide. If he is exposed to cyclophosphamide, I try to give him rituximab. If he is exposed to both, as far as the initial regimen is concerned, I try to add mycophenolate mofetil to this to see if at all he's going to respond to this battery of these four drugs, the fourth one being the corticosteroid.
Okay, there's another question, a pressing question. Long-term maintenance therapies with rituximab as maintenance. Do you repeat Hep C, hepatitis C, and tuberculosis testing?
Absolutely, because this is a situation where you don't use rituximab whenever they have hepatitis B or tuberculosis. So that is something which we periodically look into as far as these patients are concerned.
Monisha from Visakhapatnam wants to know, can leptospirosis cause pulmonary renal syndrome, and what will be the treatment for it?
Yeah, of course, needless to say, leptospirosis is one thing, but mostly it's hepatorenal rather than a pulmonary renal, but sometimes it can also cause pulmonary renal. Third generation cephalosporin, doxycyclines, and meropenem, along with a host of supportive therapies, is what we institute for them. Predominantly hepatorenal.
Is there a difference in the onset of treatment response with reference to cyclophosphamide versus rituximab? And which is faster as per your experience?
As shown in one of the studies over here, where the rituximab study, what they have shown is when you combine both, you have a better response. And also in the rituximab, in another study, what they have shown is the rituximab is the one which induces remission much early, and also it is the one which is helpful in a patient who is coming with a relapse as far as inducing the remission is concerned. So among the two, if they have a milder disease, not a very severe one, not without an alveolar hemorrhage, which is needing a ventilation, or not with a renal failure, which is needing a dialysis, probably rituximab is the one which can induce a remission much early and can be used along with corticosteroids. But if you have a patient who has an alveolar hemorrhage, which is severe, needing ventilation, And also with a renal failure, which is needing dialysis, probably you need to combine both these to achieve some amount of remission at an early stage.
There is another very interesting question. Why is the therapy moving from targeting T cells to targeting B cells using rituximab?
Yeah, this is a paradox which is intriguing, which was intriguing for a long time, because whenever we're talking about diseases which have granulomas, it is predominantly a T cell mediated disease, because a granuloma is a T cell mediated disease. But what we have found is, as far as ANCA-associated vasculitis is concerned, there's a significant role as far as the B cells are concerned. The ANCAs, they activate the B cells, and these activated B cells, they produce more ANCAs. So that is how there is an importance as far as the B cell suppression is concerned. Another important thing is the B cells reduce the anti-inflammatory nature of the Treg cells. So these are the two important areas which have made us realize that suppression of B cell is also important. And that's the reason why from a predominantly non-specific or a T cell mediated therapy, we are slowly moving towards a therapy which is including a B cell medication.
These patients with the pulmonary renal syndrome who progress to end-stage renal disease, are they eligible to undergo renal transplant?
Absolutely. But what we need to see that the disease is quiescent for at least 6 to 12 months before we take them for renal transplant. It's always better to leave them on dialysis for at least 6 months to 1 year, because that will quell the activity of the disease, make the disease quiescent, so that is the time where you can put in a new kidney for them, not the active phase of the disease. In the first 6 months, an absolute no. The earliest point would be 6 months. Personally, I would feel it's better to wait for 12 months before we ask them to go for a renal transplant.
Can lupus patients have ANCA?
Yeah, of course. Lupus patients can have ANCA, especially for patients who have class 4 lupus nephritis. They are the ones who can have this ANCA.
Dr. Sagar Gandhi from Nagpur, how do we monitor renal involvement, and when do we label the disease as refractory?
The renal involvement is essentially by looking at the GFR and the proteinuria, or the surrogate of GFR, the creatinine. So that is how we monitor the renal part of it. And we categorize them as refractory only if there is no response at the end of 6 months, despite our best efforts, which includes cyclophosphamide, rituximab, along with the corticosteroid.
Another interesting question. Are there any other extracorporeal therapies other than plasmapheresis to treat these patients?
Since plasmapheresis is essentially looking at removal of antibodies from the blood, a couple of adsorbent columns were tried. That's the immunoadsorption was tried, and it's still being tried, though not conclusively. The studies are going on as far as immunoadsorption columns are concerned, and probably we may get more information as far as this is concerned. This is similar to what is being done as far as the renal transplant scenario is concerned, where we try to remove the preformed antibodies in somebody who is highly sensitized when we are putting them for a transplant. Another interesting thing which was extrapolated from a transplant scenario into this scenario is in a pulmonary renal syndrome, we are looking at a host of antibodies, especially when there is a double positivity or anti-GBM disease, a host of antibodies which are targeting the glomerular basement membrane or the alveoli. So is there any drug which can attack the antibody and see that the antibody is destroyed? So one such particular drug which was used in transplant, which is still being worked out, and which is being tried as far as this is concerned, is the IDIS. The IDIS is an anti-IgG antibody. So an IDIS, the moment you give IDIS is going to destroy all the antibodies in the next 6 to 12 hours. So in other words, the patient's antibodies are totally destroyed in 6 to 12 hours after you give IDIS. So this is something which is an interesting scenario as far as the renal transplant is concerned. But there are some problems as far as this is concerned in transplant where you can't use more than 2 doses and the effect fades after 14 days and you don't know what to do after that. You need to come for traditional therapies. But that is not the case as far as anti-GBM is concerned because it's a single hit thing. So people are trying to use IDIS as far as this is concerned where they can give this molecule, see that all the IgGs are destroyed. And since it's a single hit, and you can manage these patients with a conventional immunosuppression later on.
What is the duration of maintenance therapy for patients with anti-GBM disease to attain remission?
Actually, as I told you,
slides, could you just elaborate on that?
As I told you, this is a single hit one. So once they achieve remission, probably you don't need to use any maintenance therapy if it's an anti-GBM alone, unless it's a double positive. If it's an anti-GBM alone, and the moment they attain remission, that's the end of it. You don't have to do anything. He has come out of it.
Dr. Achildat from Jaipur wants to know drugs which can cause ANCA-associated pulmonary renal syndrome.
The host of several drugs like propylthiouracil, minocycline. There are several other drugs. You need to go into those lists always to see if most of the times it's the propylthiouracil drugs, which are the other drugs are not that frequent. It's the propylthiouracil is the one which we want to have a look at it. And if it's a drug-induced one, apart from the interesting thing is apart from stopping the offending drug, you need to give immunosuppressive medicines for these patients. Withdrawing the drug alone is not sufficient.
And I also believe that toxins like cocaine are also notorious to produce pulmonary.
Absolutely. Because cocaine is not here, I almost wanted to say, but I stopped because it's not there. It's levamisole, which is contaminated with cocaine. So that's the culprit. So people who take levamisole, who take cocaine, have this levamisole. So it's the levamisole which is the culprit when people are taking cocaine. But that's not common in this part of the world, so I didn't come up with that.
Thank you. There's another very interesting question. Actually, it's from Trivandrum itself by Dr. KV, and who's asked, analogous to staphylococcus as a cause for relapse in GPA, have you ever seen pulmonary TB as an inciting antigen? And if so, how would be the induction regimen be different in such a case?
Well, I think I need answers from you as far as that is concerned. Because pulmonary tuberculosis, it comes very late to me. Probably you guys will be the ones who look into it. You may be a better person to answer that than me.
No, the question is whether it can be an inciting antigen for GPA.
Of course, a trigger can be anything. It can be a staphylococcus, over which there are several papers are concerned as far as the nasal staphylococcal carriage is concerned. It can be an inhalant like a petrol fumes or something. So it can be anything. Probably tuberculosis, though I'm not privy to that information.
But then I think if it is TB as an inciting agent, I think we'll have to treat them with full antitubercular treatment along with...
Absolutely, that makes sense.
So, I mean, there's a lot of comments and appreciation also coming up in the chat box for that excellent talk and for having patiently answered all the questions. And we have covered all the questions which have come up in the chat box. We have answered all the questions of the audience. Let me take this opportunity to thank Dr. Sashi Kiran for that wonderful talk and also for answering all the questions very lucidly also. And I'll also like to take this opportunity to thank CCI for having organized this CME and for having me here as moderator for this session. And also thank all the people who have logged in today to attend this meeting to make it a grand success. Thank you all. Thank you, Dr. Sashi Kiran.
Thank you so much, Dr. Arjun. And particularly, I want to thank Dr. Vijay, a close friend of mine, who made this possible, and also the CCI, and also all the audience, especially those people who have asked questions. Thank you so much. The pleasure was mine.
Thanks.